Last but definitely not least, we have Tom Kehoe from the Cancer Council of Victoria. Tom is also an academically trained historian in German history, I think. Is that right, Tom?
Yeah, notionally.
So formally, Dr. Tom Kehoe is the historian at the Cancer Council of Victoria and head of its Heritage Project. He's also a lead partner investigator on an ARC linkage grant that Brad Underhill and I are working on called Cancer Culture, which explores the history of public health campaigns to control tobacco and skin cancer in Australia. Just use the arrows.
Just use the arrows.
Yeah. Do you need that slide bigger? I can make the slide bigger for you.
Yeah. Oh, cool.
Yeah.
Thanks. Yeah, thanks for having me. I think in the run sheet, my title was Treating Cancer Through Medicare or something like that, but I decided to change a little bit to talk about Medicare and cancer control, largely because I don't think that you can think about modern cancer control in this country without thinking about it through a Medicare socialized medicine lens. And anybody who has experienced cancer or has been around cancer or has had somebody close to them with cancer probably doesn't want to think about the extent to which that experience prior to Medicare would have been infinitely worse. If it can be, one can imagine it being worse. And I say this to people in the United States all the time. If my child who passed away from cancer had died in the United States, I would have been billed for it at a time when that's the absolute last thing you'd want to think about. And that's actually the last thing that I did think about because, luckily, put it that way, we have those costs covered. So I can't talk about all the ways that Medicare influences cancer control in this country. So I'm going to talk a little bit about how it affects some elements of the primary and secondary and tertiary prevention. And then I'm going to go back in history a bit and talk about cancer control through the history of this country in the 20th and 21st centuries. And then I'm going to focus on one aspect of that story, which is how it's affected the expansion of cancer screening, in particular, the national programs for bowel, breast, and cervical cancer. So I think it's relatively uncontentious claim to say that Australia is a leader in cancer control. That's very jingoistic, and I think working with the Cancer Council, we often internally talk about being a bit too jingoistic, but I think that's true. And that's not just because of the immense amounts of money we put into treatment facilities like the Peter Mac Cancer Institute or various hospitals around the country, but it's also because of the amount of money, amount of effort we put into primary prevention, so preventing tobacco, skin cancer, et cetera, or tobacco-related diseases, screening, which is secondary prevention, and also, of course, to patient care and treatment. Now, a big part of that history is, of course, medical and scientific. It's the advances that we've put into, the amount of money we put into research and the advances that come out of that, whether it be for chemotherapy for childhood leukemia, or whether it be, new drugs on the PBS, like the new bowel cancer one that came out in 2021, which I've got a nice picture there. But it's also for supplying, using drugs for things like nicotine replacement therapy, Champix, et cetera, or also providing for HPV vaccination to prevent cervical cancer. So that's obviously a huge part of it, is research into medical technology and treatment. But also the other pillar that makes the cancer control story so important, so great in Australia, is the expansion of access to all of the services that are required for a cancer patient. So that is preventing cancer from the very beginning. So preventing people from smoking, for instance, detecting cancer earlier, pre-cancer or early stage cancer, and of course, treating cancer. I'm not going to make the claim that its access is perfect. It's by no means perfect, and there's lots of health discrepancies, of course, but it is getting better, and Medicare has been a big part of that expansion of access. So I'm going to explore cancer screening today to sort of show how that expansion of access in particular was facilitated by Medicare, what kind of barriers it hit up until Medicare came along, and then how it's expanded since then. First, I'm going to give a brief history of cancer control in Australia, because I think that we have, it's very easy to put cancer out of our minds, because like most people, I think we spend a lot of time not thinking about about the disease. We don't want to get it. We don't want to know people who have it. We don't want to think about the consequences of it. But it's astonishing to me how recent many of the key discoveries in cancer control are in medical history. If you think about the discovery of the BRCA gene, which guides, which is determinative for about 10% of breast cancers, that's only discovered in the 1990s, and its consequences for cancer epidemiology were only proven in the 2000s. So for millennia and coming into the 20th century in Australia, cancer was one of the most feared diseases. And I think it probably remains so, and that's why we don't think about it. And that's largely because for millennia, the treatments were virtually non-existent, or that what treatments did exist were horrific. And that image there is of the mastectomy from the 18th century. It's just horrible kind of punishment of people. New scientific methods, of course, like all things with the Enlightenment, were applied to cancer and decided to reveal cancer causes, things like soot causing testicular cancer, etc. And also sort of proto-epidemiology through the 19th century began. And with the beginning of the 20th century, we have the first truly efficacious treatments, starting with radiotherapy, that actually show a way of treating cancer. And this burgeoning of science and the rise of new treatments leads to the rise of not just anti-cancer organizations like my own, Cancer Council Victoria, sounds like I own it, but like organizations like mine, but also the investment in hospitals and other sort of dedicated cancer organizations. And so through the 20th century, we see a real dramatic improvement in patient outcomes and survivability for a lot of cancers. Things like testicular cancer go from 95% mortality to 5% mortality, same with childhood leukemia, and other cancers become entirely preventable. So we know that lung cancer is largely preventable if we stop people smoking. We know that cervical cancer related to HPV is preventable if we vaccinate people young enough. It's a huge progress, but through that period, through the birth of the kind of anti-cancer movement in the interwar period, and that's when it really starts after World War I, we don't see an expansion of these new services, new hospitals, new treatments to much of the population. They're heavily urbanized and they're heavily located and limited to people who can afford them. There is a concerted effort by a lot of activists during this time and to expand effort. Cancer Council Victoria, the ACE, and the trade unions, in fact, are big on busing people in from rural areas to urban centres for treatment, providing housing. That's also with the Country Women's Association, but largely this is an ad hoc event. But from the very beginning, it's also recognized that key to preventing cancer and helping lower the burden of disease in the population is its early detection, which is often called in the early 20th century prevention of cancer, meaning to prevent it going further in the body rather than how we admit it now. And that leads to this sort of marketing of the idea that people should be self-checking, self-screening, which is ultimately futile. But with the development of the cervical screen, we get a real game changer. We can detect cancer asymptomatically. And through the 50s and 60s, all those efforts to expand access to cervical screening to enhance treatment gain momentum. Here in Victoria, for instance, we get union movement, and we also get Country Women's Association, other local councils and stuff, helping people come into the cities for cervical screening in order to catch disease before it starts and hopefully treat it effectively. This, however, hits a roadblock for a number of reasons. One is financial. You have to reimburse doctors for doing the test, and you have to reimburse pathologists for testing the test. But you also need the infrastructure for keeping records of people's testing. So cervical screening in particular, if you do the screen and you find cancer, great, you put somebody in for treatment, but usually what you're looking for is changes in their cytology over time. And so you need the records to be linked. And up and through the 60s and 70s, we don't have the infrastructure or the technology to make that possible, or the financial resources to allow people to create that infrastructure. That's solved in Victoria, kinda, by having only one hospital do cervical cytology. So it's all done at St. Henry's Hospital Prince Henry's Hospital, not St. Henry's Hospital, Prince Henry's Hospital, on St. Kilda Road, and they keep us a record of all cytology results, and so everybody is to go there. But then, of course, you have the access problems. You have to get people in from the countryside to put them up. It's an unfeasible. It's not a long-term proposition for general preventive medicine. This problem isn't solved during the 1970s. It hits a roadblock. Here in Victoria, Cancer Council works very keenly through its then director, Nigel Gray, to get all hospitals and all doctors and pathologists around the state on board with the idea of doing cervical screening, which they all agree to eventually, bar a few. But of course, there's no infrastructure to allow them to do it. So they hit this kind of wall. At the same time, however, we're also getting two other tests that are getting proven for early detection. Mammography, which is actually older than cervical screening. It predates cervical screening as a technology, because it's X-ray technology. But there's studies demonstrating its efficacy in showing pre-symptomatic cancer begin to come out in the 1970s. There's the fecal occult blood test, which is the blood test that tests stool for signs of bowel cancer. These, of course, face the same problems. They face the same infrastructure problems. They face the same reimbursement problems, financial problems. And we hit a wall at the end of the 70s where basically all testing is confined to a few hospitals, or is done around the state very ad hoc. People have to go see the same GP to make sure that their cytology is maintained, or that their breast condition is maintained, the records are maintained. And that ends. Of course, we've all heard through today that Medicare comes in 1984. It's a huge game changer for these programs. And following the launch of Medicare in 1987, there is a Australian Health Ministers Advisory Council meeting, or AMAC meeting, over a series of months. And they produced a report called the Health for All Australians Report in 1987, or 1988, somewhere in there. And that report set specific goals for reducing cancer burden through primary and secondary prevention. So primary prevention through things like tobacco control and skin cancer awareness, which lines up with the already aggressive anti-tobacco effort and the SunSmart effort, or then slip, slop, slap effort. But also builds on the evidence that's emerging from overseas studies on the efficacy of early screening for not only reducing the cancer burden, disease burden in the population, but also for reducing the cost to government. So the general rule is, when it comes to these programs, if you talk to people who've advocated for them, and one of my interviewees, Jim St. John, is a major force behind national bowel cancer screening. He's now 87, he's a great man. Because you need 3 studies. This is actually kind of general rule. 3 studies from overseas that demonstrate the efficacy of a program to reducing disease burden. This is to convince government, by the way. And they also need to demonstrate cost benefits. So either break even, so the cost to early intervention is break even with the treatment, or it saves money. The Hawke government announces the launch of cervical screening nationally in 1990 and breast screen immediately after in 1991, on the basis of 3 studies for each of them, and the costs being neutral, so disease reduction, but cost being neutral. National bowel screening studies are a bit further off, and they're finalized in the early 90s. They're taken to common law in 1994 on the idea that, on the same logic, that there should be a national bowel screening program. Unfortunately, she approves a pilot program in 1994, but then when the change of government in 1996, that's stalls. And so we have a pilot program that goes through the 90s through to 2007. Then national bowel screening was launched by the Rudd government, but only for certain age bands. And then that stalls under the coalition government, and it's finally approved. They kind of got it there. Greg Hunt, I'll give him credit for that. Got it there for national bowel screening is now universal for ages 50 and above, or 74, sorry. That happened in 2021. So there's a delay in government. How does Medicare fit into this? You cannot do any of this without Medicare because national screening requires record linkage across the country. It also requires all doctors and pathologists to be reimbursed, and it requires all the tests to be covered, cost of tests to be covered, all of those things. So you need to cover the cost of the kits that are being sent out. You need to cover the cost of the screens and the now HPV testing kits. One of the great things about the cervical screening program is with the discovery of the HPV vaccine at the University of Queensland in the 1990s, cervical screening has turned from cytology, as many of you will know, to HPV detection. And we are now one of the leading countries on track for cervical cancer elimination by 2030, although I think the COVID pandemic has pushed us back a little bit to 2030. Somebody will be able to tell me that. Anyway, so this is kind of the summation of the story. Medicare helps solve all the problems of implementing a national early detection program. It covers the cost of frontline doctors and pathologists and the tests themselves. It covers the cost for the 3 essential programs that we have today. And as I kind of got ahead of myself in my slides there, it allows Australia to, with now HPV vaccinations, backed up by screening and then backed up by treatment of a few extant disease cases, the elimination of cervical cancer, which is a fantastic outcome if it were to happen. So on that hopeful note for the implement of Medicare, I'm going to end there for the day because it is late and not go any more into the dark limits of cancer screening. But there are limits to access, but hopefully what I've demonstrated is that Medicare has provided the means to create the access available to the rest of to as many people as possible in the country. Thank you very much.
Thank you.
No, everybody's exhausted.
Yeah.
I'm curious to know what would be the next area of screening program you would do?
Lung cancer. It was announced a few months ago by Mark Butler, and it's legislated to come in 2020. It's five. Thank you. 5.
So what's that going to be? Chest X-rays on every 1 of 4
Yes.
or something?
Yes.
Like the old TV program?
It's opt-in. So you have to nominate yourself as a high-risk smoker, and then opt in for lung cancer screening. The evidence for it is as I'm not a medical doctor, but the evidence for it is pretty good. But I think that it's a little more speculative. And one of the concerns is that because it is opt-in and it requires somebody to admit. There's a lot of psychological barriers that you can imagine coming up around it. If you think about opting into saying, I'm a high smoker, I'm likely to have lung cancer, I'm going to go and get screened. It's kind of.
But on the other hand, when the government's offering something that says to people, this is something the government wants me to do,
True.
it actually has a huge effect.
True.
It shifts the dial.
True.
And that will involve a lot of talks between, patients and doctors and nurses. So, yeah, I think that'll take up a lot.
Yeah, but no, that's the next one. So yeah, lung cancer screening.
I had a follow-up on that as well.
Yeah.
I'm just thinking about an area that's probably under research, so it's oral cancer. And it's not, and there's actually been paper around cost effectiveness of that. I mean, again, probably targeting the high risk, but I guess, how do we get appetite for to sort of get other cancer screening programs up with under research?
Yeah, I mean, it's interesting actually because in the late 60s there was a flurry of studies done in oral cancer that Cancer Council supported. We've got all the grant documents and all the findings, and it's really interesting. And then it just disappears. And it seems like I'm not going to talk about the Victorian case here, but there were a few people at that time who were interested in it, and then they and the guy who I'm going to forget his name, but he it was a PhD student and he was doing the studies, and then made a case for doing the epidemiology of it, because you kind of need to demonstrate population effect to get a screening program up and running. And that's where the record ends. So I think because he wasn't from Australia, so he was I can't remember, Singapore or something like that, and he left the country. So it's just like, but it's a good point. I think the three study longitudinal study rule kind of applies to convince government to get a screening program off the ground. That seems to be not just an Australian situation; it happens in other places too. So a lot of European countries only have cervical screening and breast screening. They don't have bowel screening because they don't haven't done the internal studies that they would argue are necessary to make it, to legitimize the investment. So Finland's a good example. It doesn't have bowel screening. Yeah.
Jim.
Yeah. How are the risks of screening taken into account in this? Well, I work in the School of Public Health in Sydney, which has a very long tradition of criticism, particularly breast cancer screening.
Yeah, that's true. Yes. Yeah. Yeah. Right. You're talking about like the overdiagnosis. Yeah. Well, you might know that Richard Burton, who was former CEO of Cancer Council, held that position as well. And there's the argument about not just sort of overdiagnosis of benign or semi-benign tumors and overtreatment with surgery or radical mastectomy or whatever. At the moment, I mean nationally, well, it's just kind of ignored. It's, I mean, the general position on breast screening is that it's a net good, but it is vexed, and it has derailed other programs, of course. So like prostate screening is probably rightly, I'm just taking a position that I probably should, but it's probably rightly kind of derailed as a national screening program. But there's an interesting paper, and we could talk about this another time, around why breast screening got authorized in 1991, and it's bundled together with cervical screening. So, and they're shopped to the government as two parts of the same, as the issue of two parts of a program around women's health.
What, to destigmatise cervical screening?
I can't. I'm not. Yeah, I don't know if it was so stigmatized because it's been around. It's been widely kind of destigmatized in more the 60s, 70s. But I mean, it was horribly stigmatized in the 50s, and there's a huge debate about whether we can encourage women to do this thing that's both invasive and maybe produces false positives and cancer phobia is the term. But when you get to the 90s, it's not so much. It's just, I think there's a huge advocacy for it. I guess I know the objection.
All right, thank you, Tom. Thank you very much. All right, well, I think it's probably time to wind up because it's late and it's been a long day. Thank you very much to all our speakers, and thank you people who have attended. It's been great, I think, to get people from all sorts of different areas together, academics along with practitioners and people who work in community health centres and in government, etc. I think there seemed to be a fairly positive mood in the room about the Health Minister, Mark Butler, and overall, perhaps except for Edward, a positive feeling about Medicare overall. And as Mark Cormack talked about, we have political cycles or or policy windows. At the moment, it seems that some optimism that a policy window might be open in terms of how we go about reform. Interesting questions about where we have public discussions about what kind of reform needs to happen. But by the same token, there seems to be quite a bit of agreement about what some of the kinds of reforms that need to be done. It's more a question about how we actually get them done. And then just putting in a bid for the sort of approach I had, we also have to have these broad discussions about the kind of society that we want to be, and how much we value things like a public health system, I think, as well, and how we fit that in with broader trends in society, for example, rising inequality, housing crisis, etc. So if we want to have a functioning, healthy public health system, where we find the money to pay for it and what we're prepared to sacrifice in order to have that. And that comes back a lot, I think, to how people envisage and imagine this thing, how attached they are to it, and how important it is to people. So thank you very much all for coming, and hopefully we can stay in touch about these incredibly important issues and keep talking about them. Thank you.